Following on from his presentation, Chris Lovegrove talks to us about the foundations for the treatment envisaged, how it can be integrated into the NHS landscape, and about his collaborators.
I think you've found something that's much bigger than you thought it was when you began.
Yeah, me too. Every time I sort of do a bit more, it seems to snowball, and I really realise actually how big this area is for people with Parkinson's. And sort of the more I sort of investigate it and get into it, the bigger it seems to be. And I think that this current grant that I interviewed for, I think when I was in the interview process and I sort of gave my presentation about it, I think a lot of the interview panel, from the feedback I received, were quite shocked that how big an area this is for people with Parkinson's, the impact it has on people with Parkinson's and care partners, but how there was actually not a great deal amount of specific work going on in it. So it's I hope that with working together we can come up with a solution that will improve the lives of a lot of people, is what I'm really hoping.
Yeah, I wonder why. Is it because there isn't sufficient medicine content for the classic biology research community?
It could be. That might be an element of it. One of the things that is quite clear from research is that anti-anxiety medication for people with Parkinson's doesn't appear to be as effective in people without Parkinson's. So it's not quite as simple as give somebody some medication to reduce their anxiety and it makes it better. But that's a very simplistic view of it anyway. And a lot of the evidence is behind that the drivers for anxiety in Parkinson's are twofold. One, there's the anxiety that's very well documented from living with a long-term condition that lots of people experience, but that actually, because of how the role of dopamine in people's brains, of how it modulates your sort of your fight or flight system, your warning system in a bit of your brain called your amygdala, that actually when you have less of that dopamine, that system fires more readily. So the idea behind it is actually, if you've got less dopamine, your fight or flight system is more prone to firing all the time, which generates those feelings of anxiety. So I also think that one of the reasons it's not become a particularly, that's not the right term, it's perhaps not been focused on as much, is there's historically in research, in clinical research, there has been a mismatch between research priorities and that's a lot better over the last sort of 10 years or so, with the real focus on involving participants in designing research, developing research. But it also could be that such a big focus in healthcare has been on reducing people's falls, improving mobility, that's been really, really focused on. And some of the symptoms that are less visible, immediately measurable, perhaps have a less immediate impact on, say, inpatient admissions to the NHS, have perhaps not been as focused on for a little while. And now actually that balance is starting to shift. And especially with some of the work that Parkinson's UK have done, where they've highlighted that there's actually lots of other things that people with Parkinson's think are research priorities, I think it's starting to shift more towards issues like anxiety, depression, all of these problems being focused on more.
Where is the dividing line, if there is one? How do you shade from anxiety as a natural consequence of the situation you're in to it being what the clinical community would regard as a mental deficit?
So the way that we're looking at or conceptualizing anxiety in our research is not as a mental health disorder or challenge. It's a non-motor symptom of Parkinson's that we are specifically targeting to help people with Parkinson's live better with. However, that's not to say that nationally, obviously, anxiety is often treated as a diagnosed mental health challenge disorder. And within mental health services, often you need a diagnosis of an anxiety disorder to progress through the treatment system. So the way that we're approaching it in our research is that something we can't change. So that's something we're going to have to sort of incorporate in somehow. But the way we've managed it in our research is in the development of the intervention, and in the development of the intervention and all of the work I've done over the last few years preceding this, we've invited people with Parkinson's who self-identify as living with anxiety and having anxiety. Because I think for us, particularly me as an occupational therapist, a person's what we call lived experience of their emotions, of their condition, is far more important than if you tick a box on a piece of paper, for example. I certainly I've worked with lots of people with Parkinson's over the last few years who have anxiety that is really, really, really high on all of your diagnostic scales, that impacts on massive amounts of areas of their life. Similarly, I've had people with Parkinson's who perhaps wouldn't trigger a formal diagnosis of an anxiety disorder, but actually, as far as we're concerned, their anxiety, the impact of their anxiety on their life is just as valid as the other group of people.
Yeah.
And where the challenge for us is going to lie, and the next step of our research after we've developed the intervention, is in research, one of the bits when you get to testing things on a large scale, you need to have tick boxes, you need to be able to put things in boxes to analyze data and things like that. But the way we have done it at the moment is we have, and this is going to be something we're going to discuss with people with Parkinson's at more length. One of the ways that we're going to do it is to use a very specific and general anxiety screening tool that has been what they call validated with people with Parkinson's. And we're going to use that to identify people that, one, this intervention is likely going to be most effective with. But two, it will allow us to align our research outcomes with the national programs that are already in place. Because what would probably not work so well is if we used a very specific Parkinson's intervention or Parkinson's anxiety screen, for example, that we just used in our study, and we found it really, really, really worked well. When we go to translate that to the National Health Service, what's already in place, there's no equivalent of it, if that makes sense. So what we're trying to do is develop our intervention in a way so that it will incorporate the needs of as many people with Parkinson's with anxiety as possible, but can also be efficiently and quickly implemented into NHS services. Because our aim is to get this out there and to help as many people as possible, as quickly and efficiently as possible. And we don't want to get into lots of discussions with commissioners about what does this align with this. Ultimately, we want to get it out there. So we're trying to make something bespoke for people with Parkinson's that can easily be integrated into systems that are already available.
You just made reference there to an NHS integration, and sort of suffering from anxiety. I found a lot of benefits in sort of sorting out affairs in my private life, sort of just taking away those issues which make me sort of fight or flight. And I was just wondering whether the NHS would have the capacity or the ability to do that, or would they work closely with, say, PUK to develop the programme?
That's a really good question. So I think certainly when the intervention is more developed, and I have something more that we can deliver nationally, I would certainly be looking at Parkinson's UK to look at how we can disseminate that nationally. One of the ways we're trying to develop our intervention to help it be delivered across the NHS is to, and that's part of the reason for doing the feasibility trial, is that we all know that NHS services are under increasing pressure, both financially and from a sort of like a personal resource perspective. So if I went ahead and developed an intervention that takes 3 hours to do a session, and just the assessment kit is £1,500, the likelihood of it being taken up is very, very unlikely. So I think what we're trying to do is develop a goal, really what I consider like a gold standard intervention that can be delivered to people with Parkinson's in their own homes in a realistic manner. And it will likely utilize what we call self-management or lifestyle redesign concepts. For people with long-term conditions, the evidence is becoming increasingly overwhelming that if you, rather than do to people, if you give people the tools and support them to develop their own meaningful ways to maybe redesign or reconstruct their life or address different issues within that, that is far more successful and sustainable for people than if I, as an occupational therapist, just came in and fixed the problem for you, if that makes sense. So that's the way that we're kind of working towards delivering this.
That's very encouraging. Thank you.
What I'm seeing here, I think, is one manifestation of how society can deal with an infinitely escalating demand for services. You can't manage people, an infinite number of people turning up with broken legs or broken minds. You have to enable them. They can't deal with a broken leg, but they can deal with a broken mind, maybe. So if you manage the demand by knocking it on the head before it needs help. Is there too much philosophy in my analysis of what you're doing?
No, I don't think so. I think that the evidence, the research evidence is there that these sort of self-management approaches that empower people are very are successful. They work for people and they're sustainable. And I think it's quite, the fact that the NHS is under such pressure. I think it's just the ticket really that it needs to support a system that is increasingly under pressure with groups of people, people with Parkinson's, the projections of the numbers for people with Parkinson's being diagnosed over the next however many years, it's increasing. And so we need a solution that's going to empower people to manage their conditions and their lives successfully. And that aligns with my core values as an occupational therapist around empowering people with the power of doing the things that are important to them, that are meaningful to them. Because people with Parkinson's have told us in our previous research, they want to be out there doing things that their anxiety is stopping them from doing. They don't want to necessarily sit and talk about it. So for me, as both an occupational therapist and as an occupational therapist and a researcher, that's a real call to action for me. We've been told what people want, what's important to them. So now's the time to act on it.
Now, clearly, you are not going to be able to do all of this by yourself. And therefore you refer to we and us. So who is we?
The we part is I've got two organisations that I work with. There's the Royal Devon and Exeter Hospital as the clinical aspect of it, and there's the University of Plymouth. My supervisory team within my research role, and that's the we that I'm sort of referring to. My project research team is myself, Professor John Marsden, who's the chair for rehabilitation at the University of Plymouth, Dr. Katrina Bannigan, who is the head of occupational therapy and human nutrition and dietetics at Glasgow Caledonian University, and Dr. Ingrid Sterkenboom from Radboud University Medical Centre in the Netherlands, who is sort of like a world kind of like leading figure in occupational therapy and Parkinson's. So that's my immediate research team at the moment that are supporting me with bringing this to life. Alongside that, I'm incredibly grateful that at the moment Nigel is on our research team as a project collaborator, as a person with Parkinson's. And that's incredibly valuable as a researcher to add that perspective that I simply don't have. And alongside that, I'm a member of a couple of research groups, particularly in Plymouth. the Allied Parkinson's Research Group, which is chaired by Dr. Camille Carroll. So they're supporting me in my work, and Camille's been, Dr. Carroll has been a great support in helping to bring this work forward and planning for the future trial. And also the Participation in Everyday Life research group at the University of Plymouth, which is helping me to bring in more of these sort of concepts around meaningful participation in occupational therapy. So that's when I'm referring to we, and also, most importantly, all of the participants that take part in my research, because without them, this wouldn't be going anywhere at all. So in the future, I'm hoping to build more collaborative relationships with other institutions. I'm part of a research group in Glasgow Caledonian University that I've just joined, that I'm hoping to build more links there to help deliver this research in Scotland and up north. And the future, as far as I see it, the future is after we've delivered in the UK. I want to build more international collaborations to develop this research to people with Parkinson's across the globe, hopefully.
Yeah, I had another question actually. It was just around the idea that sort of Chris was mentioning the idea of sort of cost, time and money cost, as he sort of tried to quantify the savings.
The economic cost of this intervention is something that we will be looking at. So that fully won't be something we can assess until we do the full, what they call fully powered trial across the country in quite a few years' time. But what I'm going to be doing next, for the next phase in the feasibility trial, is collecting some basic economic, some like resource cost information, not only for NHS services, but for people with Parkinson's as well, because we need to get an idea of, as we're kind of testing this intervention to refine it, what is the economic health impact on clinicians, people with Parkinson's, do people's visits to Parkinson's nurses or the calls to Parkinson's nurses go down, things like that. And at this stage, it's going to be very kind of like raw collection of data to get just a sense of it, really. And the reason for that is we need to kind of like test the data collection and to get an idea of how that will work, so that when we do the full trial, actually fully powered trial that will test if the intervention works or not, then we can make some proper economic calculations about what the costs are for doing this intervention, not only for healthcare services, but for people with Parkinson's as well. I think one of the things that it's worthwhile me adding is one of the plans for the future with this intervention is obviously when you test a new intervention or when you do an experiment, you can only target a certain group of people, even within a population, say Parkinson's. And one of the things at the moment that we've had to exclude from the testing at this stage are people with Parkinson's who have quite substantial cognitive problems. And that's purely so we can get the framework for the intervention developed. For the future, one of the ways that we're going to take this is those people who are living with Parkinson's and quite a substantial cognitive impairment. How can we tailor this intervention to support that group of people as well? Okay. That was just too big to do all in one chunk, unfortunately.
Second. So thank you very much, Chris.